This is Chapter 41, Assessment of our Nervous System. So just a little bit of a review of our nervous system. Remember that your neuron is your basic component of your nervous system. It's composed basically of your cell body, your axon, dendrites. The cell body, of course, is our center of metabolism. Axons are the long fibers. They help to conduct those impulses away from the cell body. You have one axon for each and every cell body. And then the dendrites are just short fibers. They receive nerve impulses from other axons, and then they transmit impulses back to that cell body. You also have a myelin sheath. The myelin sheath helps to protect the nerve fiber. It covers it, and it helps to facilitate the speed of those impulse conductions. The primary functions of your nerve impulses is, the primary function is transmission of all of your nerve impulses. You have sensory neurons. Your sensory neurons transmit impulses from your peripheral receptors to the central nervous system. And then you have motor neurons that transmit impulses from your central nervous system to your muscles and organs. Things to be considerate of when you think about your elderly population. They have less coordination of their nerve impulses. As we get older, we lose neurons. So they have a decreased ability to maintain their blood pressure, body temperature. They have a decreased sensation of pain, touch, and of temperature as well. I think everybody knows that we as individuals could not live without our brain. The brain helps to direct the regulation and the function of our nervous system and helps it to work with all the other systems of our body. And then our spinal cord helps to start that reflex activity, and it transmits impulses to and from the brain for us. So we have three divisions of our nervous system. We have our central nervous system. Our central nervous system is composed of our brain and our spinal cord. The brain is a very complex organ, and your book goes over each and every part of the hemispheres. I'm going to kind of hit the high points. Your brain has meninges in it, and your meninges are just a protective layer of the brain. It's like a covering. The meninges help protect the brain and the spinal cord. Your outside layer of your brain is the dura mater. The pia mater is the most inner layer, and your dura mater lies between your cerebral hemisphere and your cerebellum, and that's called the tentorium. And I think we talked a little bit about your supratentorium and your tentorium last semester. So just remember that your supratentorium is above the your supratentorial is above the tentorium. Your infratentorium is below the tentorial. And that kind of helps know that if you've got injuries at the upper half, like tumors or injuries from a car accident, then that can tell us which system it may be affecting. Your major part of your brain are your brainstem, your cerebellum, and your forebrain. Your brainstem is most important because if you have any type of trauma to your brainstem, then you could be on life support for the rest of your system. So your brainstem does your life support and the basic functions such as movement. Your cerebellum helps you with coordination of movement, like walking. It does work together with the brainstem to focus on how those muscles move. And your cerebellum is located just below your occipital lobe. Our occipital lobe is responsible for how we see and perceive things. Your diencephalon lies just under your cerebellum. Your diencephalon connects your cerebrum and your brainstem. And what's important about your diencephalon is it's where your thalamus and your hypothalamus are housed. We remember that our thalamus helps control pain, temperature, touch. It's kind of like a relay station. It does sensations. It can be also responsible for things like abstract thinking, reasoning, vision, hearing. Your hypothalamus, we all know it is our kind of our thermometer of our body. It helps the entire body maintain its homeostasis. It's also responsible for the secretion of a lot of our hormones. It can help, it controls our blood pressure, our balance, appetite, body temperatures, and it's also the control center for our pituitary functions. Your hypothalamus also affects both divisions of your autonomic nervous system. Our peripheral system is composed of your spinal nerves, your cranial nerves, your 12 cranial nerves, and then your autonomic nervous system. Your peripheral nervous system has 31 pairs of spinal nerves that exit out of the spinal cord. Your posterior branches carry the sensory information. Remember, that's the how you perceive like pain and heat to the cord. That's your afferent pathway. And then the anterior branches transmit motor impulses, telling our muscles to move to the muscles of the body, or the efferent pathway. You also have an area in your body. I don't know if y'all have ever heard of dermatomes, but your dermatomes just help represent sensory input from those spinal nerves to a specific area of the skin. If you look on page 834, it shows you the dermatomes of the body and how things are affected in that particular area as to how you would feel things. These sensory receptors throughout your body kind of monitor, and then they transmit impulses of pain and temperature, vibration, pressure, and they also help to monitor and transmit how we see things, our vision, taste, smell, and hearing. So our autonomic nervous system is composed of two parts: our sympathetic nervous system and our parasympathetic nervous system. On your autonomic nervous system is not under conscious control, so it's basically those things that we don't think about, but it can be altered by people who use biofeedback and some other different methods. So here's a picture of our sympathetic and our parasympathetic nervous system, and I've got a better picture on the next slide. Remember, I'm going to go to the next slide. Your parasympathetic nerves are responsible basically for your rest and digest. So things like stimulating saliva, it slows your heart rate, constricts your airways, it stimulates the activity in your stomach, like that hydrochloric acid that's present. It stimulates the activity in your intestine. It controls your bowel and bladder function. And then your sympathetic nervous system is your fight or flight. We dilate those pupils. It increases your heartbeat. It relaxes those airways. It keeps that stomach activity from that hydrochloric acid from being in there. It stimulates release of glucose. It inhibits the activity of the intestines, which means it slows that particular part down. And then it can help promote ejaculation and vaginal contraction. The reason that some of these things are inhibited during the fight or flight is because you don't need those certain functions in the urgent and stressful situations that you may be going through. And then when you're resting and digesting, then it can help speed some of those functions up, and then it can slow some of the body functions down on the parasympathetic side. The parasympathetic side you can also think of as feed and breed. because it does help to promote erections. It also helps to, like I said, slow the heartbeat and constrict those airways. Other things to be thinking about is we have so many changes with patients as they age. So many neurological changes that can affect their mobility, and it can affect their sensory perception. These patients are slower, their response time is slower, and they are less apt to be able to feel hot and cold and sensory issues that they may have. It can also affect their daily activities because their pupils do decrease in size. This constricts the amount of light, so they may not see as well. They may need better lighting. Their cognitive function is not as it was. It can be very hard to differentiate between like dementia and depression. But please realize that even though their memory may not be as well as it should, it doesn't affect their intellect. They're still going to be as intelligent as they were, but their memory is not going to be as well as it used to be. How are we going to assess these patients? First off, we always know that we need an excellent patient history. You always want to assess their appearance, their speech, affect, how they're moving, if they seem to have cognitive deficit. Do they know what day it is, what time it is? Can they recall the last meal that they eat? You want to know about, of course, their family history. Have they had any strokes, or any family members have strokes or heart attacks? And then as far as their physical assessment, every time these patients come back, you want to be making sure you're comparing this visit with how their initial visit was. You may notice from time to time changes in their cognitive status, changes in their neurological status, and remember that a decrease in their LOC can be the first recognition of neurological problems. We also want to make sure that we're doing a complete neurological assessment. Depending upon what their problems are, some physicians can do just like a limited neurological assessment if they're having problem with one specific area of the body, or they may need to perform an entire neurological assessment on that particular patient. You always want to start, when you're doing a neurological assessment, on the highest level of functioning and go down to the lowest. Your highest level, of course, would be your level of consciousness and the cognitive status. Are they thinking properly? Do they know what day and time it is, or where they're at? Then you can go down to your cranial nerves. You've had a health assessment, so please review your cranial nerves in this specific chapter, as far as which cranial nerve controls which function. A complete neurological assessment can also help establish if there's an injury or if there's a lesion, like a tumor, located in the brain or in some neurological place in the body. And it can also determine which part, whether it's in the brainstem or the cerebellum. So that's why it's important to do a complete neurological assessment. So assessment of their mental status, that's divided into consciousness and cognitiveness. Remember, consciousness is how aware you are of your environment. Do they know that there's a picture on the wall? Do they know that somebody else is in the room with them? It's basically just your level of consciousness. Is how alert that particular person is, or how much stimulation it takes to get their attention. Then you have your cognition. That's their intellectual function, their attention span, their language learning, memory, things along those lines. Loss of memory, especially recent memory, tends to be another early sign of neurological problems. Review, remember your remote. It's remote, it's long-term memory. Ask them about their birthday. Ask them about the schools they attended. You have recall memory. That's the recent memory. If they're in the hospital, the time they were admitted or how they got to the hospital. And then we have an immediate. That's the new memory. Give them 3 words to remember and go back in about 5 minutes and then ask them to repeat those words to you. There are a lot of other ways to check their mental state, and those are listed in the book. If you look on page 839, it gives you a list of things that you can do to test that memory status. When you are reviewing your cranial nerves, remember you're testing things like your touch discrimination. You have that patient close their eyes, and you can take something as simple as a paper clip and just touch it in their palm of their hand, and then on other areas of the body. And they should be able to point to the area that was touched. Also remember your Romberg sign. That's where the patient stands and then they hold their hands straight out and their eyes closed. And if they sway, it can be an indication of a neurological problem in the cerebellum area. So just make sure you are looking into and remembering those tests that you perform and what they're called. So this is posturing. Posturing happens with neurological deficits. And this first one is your decortication. It is where the patient may have lesions down the spinal pathways. The arms, wrists, and fingers are flexed, and you have internal rotation and plantar flexion of the legs. The bottom one is decerebration. This is very abnormal, and you see decerebration with any type of trauma in your brainstem area. These patients are very flaccid, and if they've got decerebration, it's not a very good outcome. So this is our Glasgow Coma Scale, and if you don't remember, the higher the score the patient has, the better off they are neurologically. The highest possible score is 15. So remember, the higher score they have, the better off they are. The lower score, of course, the patient's neurological function is not very good. And with patients who have neurological trauma, you want to be evaluating their neurological status sometimes every hour or every couple of hours. So some of the diagnostic testing that we can do for neurological statuses are first our laboratory assessment, fluid, electrolytes, any type of glucose abnormalities can cause neurological impairment. I always want to do a BMP, a basic metabolic profile. Of course, your calcium, phosphorus, magnesium, all of those need to be checked. Anemia, malnutrition can lead to neurological problems. So can a low albumin, and especially vitamin B deficiencies. You want to do your blood gases, and also probably arterial blood gases to make sure the patient doesn't have any source of infection, because those, again, can cause neurological problems. Skull and spine x-rays. If patients have head traumas or any type of a multiple injury, the first priority is to rule out a cervical spine fracture. Make sure you always consider your patient's cognitive status. It may be that you need to take an extra person to the x-ray with you in case they get confused. Cerebral angiography or an anteriorography is a test where they are able to determine blockages in your arteries and veins in either your brain, head, or neck. It's basically what they call the gold standard for detecting intracranial vascular disease. And it's also required for any type of surgical intervention. It can identify aneurysms, occlusions, tumors, swelling. These particular patients who are sensitive to iodine, they do use a dye with this test, so you always want to check their shellfish allergies. And patients will be given a little bit of sedation for this. And they go in usually through the femoral artery, kind of like they do a cardiac catheterization, and they put dye up through there, just see how it flows through the vessels to look for the blockages. So a CT scan is used to check things like for a spinal cord injury. It can look at the brain, and it can also be used with dye to help enhance the images. Remember that CAT scans can distinguish bone and soft tissue and things like cerebral spinal fluid or blood. They can also see tumors, myocardial infarctions, hemorrhages, hydrocephalus. Okay. MRIs can also be done. MRIs have the advantage of the fact that it doesn't use radiation. They use magnetic fields, and if they see bony structures, MRIs cannot see bony structures. Your CAT scans are the best way to see bones. Remember with MRIs that patients can't have any metal in their body, things like pins or plates. You always want to make sure you do your MRI list, that the hospital has assessment list to make sure the patient is safe to go into the MRI. The PET scan is a little bit different testing. You see this used a lot of time with oncology patients. With the PET scan, it looks into how much that the tissues can take in. It provides PET scan can provide information about the function of the brain, specifically how it takes up glucose and oxygen. It can also tell about the blood flow. With the single positive proton emission CAT scan, you don't have to worry about that, or the magnoencephalography. You can read over those in the book, but I'm not going to make you know a lot about them. An EMG is a nerve conduction study. It basically is used to identify the nerve and muscle disorders as well as spinal cord disease. And this is a picture of how they will attach the electrodes to the specific person, and then it transmits these little electrical pulses through the nerve and the muscles. And it's not painful, but it is very uncomfortable for the patient. And then this is a picture of an EEG. It does transmits the brain waves to see how much brain activity a person has. And the thing you need to remember about the EEGs is they do put a lot of gel into this person's hair, and then they put all of these electrodes on them. So you want to be mindful. The patients have to have clean hair prior to putting in the gel. You could have an abnormal EEG because of brain tumors, tissue death, if you have a blockage in your blood flow, drug or alcohol intoxication can cause it, seizure disorders. Again, this test takes about anywhere from an hour to 2 hours. We'll make sure the patient has clean hair, and then after the procedure is over, you definitely will make sure that you help the patient clean up. Evoke potentials. These help to measure the electrical signals to the brain that can be generated by your sound, your vision, or light. They help assess nerve problems and to help confirm neurological conditions, things like multiple sclerosis, brain tumors, acoustic neuroma, which are small tumors of the inner ear, and then, of course, spinal cord injuries. These can also be used to test sight and hearing, especially in infants and young children. They can monitor brain activity in comatose patients and also confirm brain death. These tests basically measure the amount of time that it takes for an applied stimulus to reach the brain. Like if you put electrodes on and then say you take a pin and puncture the patient's skin, then the amount of time it takes from the time that patient feels the pain to it reaches the brain, it should be basically instantaneous. If it's not, then that person probably has some form of neurological deficit. You can also check optic nerve damage and high-frequency hearing loss with these as well. Cerebral blood flow evaluation. These are just useful in patients who are having cerebral vasospasms. You don't have to know a lot about this test. Lumbar punctures. Lumbar punctures are a really good detection tool for patients. They're used a lot of times if a physician thinks a patient has meningitis or has anything going on with their cerebral spinal fluid. This is the position that you will see the particular patient in. It's a fetal position. These patients have to be very still during this specific procedure. The physician will numb up the area and then inject in between L4 and L5. They will take some of the fluid out from the cerebral spinal and then send that to the lab to see if there's anything growing in there. Some complications of a lumbar puncture can be brainstem herniation, which you do not see very often, infection, leakage of your cerebral spinal fluid, and then a hematoma formation. You always want to make sure you put pressure dressing on the back of that site after you finish with the lumbar puncture and have the patient lay on their back for anywhere from 45 minutes to an hour. And this picture just shows the different colors of cerebral spinal fluid. The first one is the way that it's supposed to look. It's supposed to be clear. This one is what they call a bloody tap, and it's basically just blood in the cerebral spinal fluid. See, here is where they've actually gone and centrifuged the bloody tap, and the blood has gone down to the bottom. And this is just one that has been seen there for a while. So a couple of other studies that can be done. You can have a transcranial Doppler ultrasonography, and this is what it looks like. As you can see, it looks at the blood flow in the specific vein, and then you can also do muscle and nerve biopsies, and this shows the different areas that can be done in. So that is the end of our video. Thank you.